discussion on infectious disease and toxicology. The main reason is obviously infectious disease in itself is a large area that can appear in several MCQs, but we have covered most of the topics in various other specialities. So we have just a few topics remaining. Okay. Now the first question is on dengue, and by this time you should know everything about dengue, and sort of including a Saranga remind me to COVID and just a quick primer on COVID. Right? Okay, fine. So dengue can appear in your MCQs, SCQs. We've already had discussions about this in your emergency medicine classes. Okay, so true or false regarding dengue. Now, if you take the virology of dengue is that there are 4 pathogenic serotypes, then 1, 2, 3, 4. Traditionally in Sri Lanka, it has been 1 and 2 that have been very prominent, right? But we have seen 3 and 4 as well. Right. Now, if you take the natural history of dengue, you may remember that there are 3 distinct phases in the natural history of dengue, right? You have the febrile phase, the critical phase. So the critical phase is characterized by plasma leakage. And then you have the recovery or the convalescent phase, where the plasma leakage recovers and the patient recovers essentially. So febrile phase, critical phase, and convalescent or recovery phase. Now, the critical phase is important because that is where the plasma leakage occurs. And that is where most of the complications of dengue occur, in the critical phase, including bleeding. But remember, very important, write this down, bleeding can occur in any phase of dengue. Bleeding can occur in any phase of dengue. I have seen intracranial hemorrhages in the recovery phase of dengue also. So bleeding can occur in any phase of dengue, but it is far more commoner in the critical phase, right? Far more commoner in the critical phase. So the second statement that says bleeding occurs exclusively, the word exclusively means eke vitarai කියන එක එහෙම වැරදි, right? Bleeding can occur in any phase of dengue. Now, talking about clinical manifestations over the last few years, last 5 or 10 years, we have recognized a lot of unusual manifestations of dengue, right? And now we call these manifestations the expanded dengue syndrome. Expanded dengue syndrome. Lots of unusual manifestations, including a lot of neurological manifestations. Right? Expanded dengue syndrome. And in the neurological manifestations, we have seen cerebellar syndrome, right? Cerebellar syndrome. You can get transverse myelitis, Guillain-Barré syndrome, right? Optic neuritis, secondary to dengue. So optic neuritis are some MCQ at අහන්න පුළුවන් දේවල්. Optic neuritis, transverse myelitis, Guillain-Barré syndrome, cerebellar syndrome, we have seen as the expanded dengue syndrome, unusual manifestations of dengue viral infection. Right. So that is true. Statement 3 is true. Dengue IgM is the gold standard of diagnosis when the patient presents within 5 days of fever. No, it is the dengue NS1 that is the gold standard. Actually, it's not even that. It's actually the PCR that's considered the gold standard, right? PCR within the first 5 days, right? Within the first 5 days, that is the gold standard. But we don't do it beyond research purposes. So in clinical practice, we use the NS1 when they come within 3 to 5 days of fever, right? NS1 antigen. But remember, the NS1 antigen can be positive in certain other viral infections also. NS1 antigen එක dengue වලට specific නැහැ කියන එක. එතන ලියා ගන්න. Right? But the gold standard is the PCR, which we don't use in routine clinical practice. Hari. Okay. I've talked about the dengue NS1. Somebody has asked, so actually, we don't really know why bleeding occurs in dengue, right? That's still under some sort of, we're still researching on these topics. Why? What is the exact pathogenesis of bleeding in dengue? So purely from an exam point of view, nobody is going to ask this to you from you, right? Because we don't know why bleeding occurs in dengue. But there is evidence from a study that we did that there is probably a problem in platelet aggregation. That paper is going to be published soon. But there is a problem in platelet aggregation. Again, platelet ඇලෙන එකේ තමයි ප්‍රධාන ප්‍රශ්නේ තියෙන්නේ කියලා. Right? It's not really the platelet count alone. It is mostly platelet aggregation problems or platelet functional problems that cause the bleeding. There is reasonable good evidence or preliminary evidence to say that based on some research that we have done. Hari. Okay. Fine. So, Edika Hari. Right. So these sort of classifications we have talked about before. I'm not going to take time in going through them now. And I've talked about the phases. Right. Now, this MCQ focuses on the critical phase of dengue. Now, how do you, what the hallmark of the critical phase of dengue is plasma leakage. Now, traditionally, plasma leakage was defined as rising hematocrit more than 20% of baseline. That was a traditional definition, right? Traditional definition of plasma leakage. Rising hematocrit 20% from baseline. Right? That is a traditional definition. But now, ultrasound is used more and more. And there are now ultrasound definitions also that can define the critical phase, ultrasound definitions. But not gallbladder wall thickening. Gallbladder wall thickening, but say pericholecystic fluid, hepatorenal pouch fluid, pleural effusions, ascites. So pericholecystic fluid, hepatorenal pouch fluid, pleural effusions, and hepatorenal pouch fluid, these are considered to be ultrasound markers of plasma leakage and the critical phase. Right? Ultrasound is used more and more, and the wards should have seen this being used. Now, as I told you, the traditional standard definition was hematocrit 20% from baseline. That was a standard definition that we used. Right? So, second statement is false. But now there is research again, which originated from some of the work that we are doing, showing that no, the hematocrit rise doesn't have to be 20% to signify bleeding. It can be much less. So estimates between 10 to 15% rise from baseline also have been associated with leakage. So this 20% thing is probably inaccurate, but still in most of the guidelines, right? But probably inaccurate. But statement 2 is definitely wrong. Right. Leakage is maximal at the onset of the critical phase. As you know, the leakage is maximum at 24 hours from onset. So it's like a bell-shaped curve. It rises to 24 hours and then drops down after that. And as you remember, the critical phase is a period of 48 hours. Right? Okay. Now, when we were medical students, starting off pediatrics and medicine appointments a long time ago, people used to give platelet transfusions for people with a platelet count of less than 100,000, right? Prophylactic platelet transfusion. We now know that that is useless and can be harmful also, right? Because when you give platelets, remember, it's a blood product. You can get anaphylaxis and allergic reactions to it. So there is a recent clinical trial, again a few years ago, that looked at prophylactic platelet transfusions. And that was absolutely useless. It was more harm because it caused more itching and anaphylactic shock and all of these things. And didn't have any outcome improvement. So prophylactic platelet transfusions are absolutely useless in dengue. Right? And probably even to a patient who's bleeding, giving platelets is probably useless also. Right? So platelet dene ke kisi වැඩක් නැහැ. කියලා මතක තියාගන්න. Right. Now, okay. Now, in the acute medicine discussions, I told you this ABCS thing. So when you have a patient in the critical phase, so he's in refractory shock. Refractory shock. ABCS should be corrected or thought of. A කියන්නේ acidosis, B කියන්නේ bleeding, C කියන්නේ hypocalcemia, and S කියන්නේ hypoglycemia. So in a patient who's not responding to fluids, not responding to colloids, always consider ABCS, acidosis, bleeding, calcium, hypocalcemia, and hypoglycemia. Through it තමයි දැනගන්න ඕනේ. Hopefully all of this is now in your brain and ready for Friday. Hari? Right. Any questions about dengue lamai? Remember, dengue can appear anywhere in your paper. Hari? MCQ, best response, SCQ, ඕන තැනක එන්න පුළුවන්.
Excuse me, sir. Sir,
Yes.
fluid hypovolemia එකක් එක්ක මේ fluid overload symptoms තිබුත් මුලින්ම දෙන්නේ colloid එක steroid sir මේ hypertension එක.
හරි. ඒ වගේ වෙලා බොහොම පරිස්සම් වෙන්න ඕනේ. If there is evidence of hypovolemia with fluid overload in dengue. So hypovolemia with fluid overload. Hypovolemia කියන්නේ මේ low blood pressure with fluid overload වගේ තියෙනවා නම් you have to be very careful because that might be actually dengue myocarditis. That is rather rare, but rather nasty when you get it. So you have to be very, very careful. So when there's hypotension with pulmonary edema or fluid overload, that is a very dangerous situation. So obviously they will need ICU can looking for myocarditis. You have to be very careful with fluids in those sort of people. And again, that is a bit beyond your expectations from a medical student to know because those are all complicated ICU stuff. Chanuka can generalize. Okay, so that is an unusual thing about dengue, which probably we still don't know really why it is. Dengue causes leakage only into the third space, that is pleural effusion, ascites, never into the peripheral tissue. We really don't know why, but that's something unusual about dengue. And this is all sort of global research agendas නේ. දැන් ඩෙන්ගි ගැන මෙච්චර අපි දන්නේ නැත්තේ ඇයි? මොකද කවුරුත් ඔක්ක රිසර්ච් කරන්න උනන්දුවක් නැහැ. UK වල නැහැ, ඇමරිකාවේ නැහැනේ. If dengue was like COVID, we would have found a fantastic vaccine and some treatment for it by now, right? So these all these politics and sort of science agendas. Right? අපි දන්නේ නැහැ ඇත්තටම, but it doesn't cause generalized edema. It causes edema in the fluid in the third space, that is in the pleural fluids and pleural cavity and the peritoneal cavity. Okay, so let's move on to leptospirosis. Now, leptospirosis again is a very nasty infection and is carried by rats as the reservoir host. But remember, there is a lot of work coming out of Anuradhapura by Agampodi who shows that rats are not the only reservoir host, right? And that in Sri Lanka actually miharak get leptospirosis, buffaloes, right? And there are also other reservoir hosts, not only rats. Right? Now, leptospirosis, the nasty form, is actually mostly immune mediated. The nasty form which causes pulmonary hemorrhage and renal impairment, and probably a lot of immune mechanisms which are playing a part there. Right? Aseptic meningitis occurs as a complication. That is true, right? So that is an unusual manifestation of leptospirosis. Sasanka haltena dengue prashnak entered into shock, and we have so Sasanka, when a patient has entered into shock, we have already given the full fluid quota. What should you do? So actually, Sasanka, now the actual fluid quota is about, say, 4 liters. You can actually give about 6 liters without much of a problem. Right? But if you are giving more than that, better to give more colloids and then sometimes use a bit of furosemide a little bit more liberally when the patient starts to go into the recovery phase. These are all very complicated topics that are more sort of higher level discussions. Right? These are all practical things. You can go up to about 6 liters without much of a problem. But then you have to be very careful after that. Right. Now in leptospirosis, the main problems are that you get a you get a renal impairment. That is a main life-threatening problem. In addition, you can get a pulmonary hemorrhage, which is even more dangerous. Right? Pulmonary hemorrhage again, ගොඩක් අය මැරෙනවා. Now, there is liver involvement and a rise in ALP, but there is no liver necrosis as such. So this third MCQ is wrong. It causes, in a way, it causes a rise in ALP, but there is no major liver necrosis in leptospirosis. Right? So I told you most of the pathology is immune mediated. Renal impairment and pulmonary hemorrhage are the dangerous life-threatening problems. ALP can go up, but there is no liver necrosis as such. Right. Okay. Now, there have been lots of debates about the gold standard for leptospirosis diagnosis. Lots of debates. Currently, for all practical purposes, we consider MAT, microscopic agglutination titer, as the gold standard for all practical purposes. Right? Practical purposes. But there are lots of debates around that. දැනට අපි microscopic agglutination titer එක තමයි gold standard විදිහට පාවිච්චි කරන්නේ. But there are lots of arguments and discussions about that, right? Problems of that. Now, I'm going to show you the next slide also. Now, this is very important. එකපාරක් මේක SCQ එකත් අපි ඇහුවා. How would you compare and contrast dengue when somebody comes with acute fever කියලා. නේ? So this table gives you a sort of comparison of dengue and leptospirosis. The key things that I would like to show you are in the investigations. So in leptospirosis, there is a high white count with a neutrophil leukocytosis, right? And a lot of urinary sort of protein, red cells in the urine, අපි නිතර දකිනවා, right? Red cells in the urine, protein in the urine, and a high CPK, right? So that is the sort of profile of investigations you would see in leptospirosis. Another very important thing in leptospirosis is that you should be able to elicit a possible contact history, right? A sort of environmental exposure to the organism, right? That is something that you need to demonstrate in the history clearly, right? ඒ කියන්නේ ඔය මොකක් හරි මේ sewage worker කෙනෙක් හරි එහෙම නැත්නම් කුඹුරු වැඩ කරන මිනිස්සෙක් හරි එහෙම there should be some sort of environmental contact history, right? In order to diagnose leptospirosis. Now, leptospirosis treatment is very tricky and often it is supportive, right? We do give antibiotics, but antibiotics have never been proven to reduce complications, right? Please write that down. So antibiotics are there, but they have never been proven to reduce complications. The reason for that probably is that this disease is immune mediated. So most of the complex disease, the life-threatening disease, is immune mediated. And people have tried various immune strategies for this, but really none of them have been conclusively proven. සමහර අය steroid දීලා තියෙනවා, right? Some people have used plasma exchange. Some people have used IVIG, right? Various types of things have been done, right? But none of them have proven to have any benefit. And antibiotics also, there is no real evidence or clinical trial again that it has any benefit in reducing complications. So fifth MCQ is false, right? But again, leptospirosis ලෝකේ හැමතැනම තිබුණා නම් මෙලහකට we would find it, would have found a treatment for it, but unfortunately that is not the case. Okay, right? Any questions about leptospirosis? Okay. Question 4 is on scrub typhus. So just නිකන් MCQ එකක් මම දැම්මති ඔය ඉඳලා හිටලා අහන්න පුළුවන් නිසා. Scrub typhus වල Oriensia sutsugamushi is a pathogenic organism, right? Now, scrub typhus, the classical presentations are it causes a bloody high fever, massive fever spikes. So that කන පැලෙන්න උණ හැදෙනවා, right? Intermittent, very high spiking fever. The other typical thing that you can see is this rash, right? Maculopapular වෙන්නත් පුළුවන්, or it can be a vasculitic type rash as well sometimes. And you know the classical are Eshka. Right? So that's a typical. So fever with a rash, a scar, that is very typical of scrub typhus. Now remember, lymphadenopathy is very common in scrub typhus. Lymphadenopathy. And you can get splenomegaly also, right? Lymphadenopathy, splenomegaly is quite common in scrub typhus. And that's important. And actually it's useful sometimes to differentiate leptoform dengue from scrub typhus. So again, they were lymphadenopathy and splenomegaly. Deafness is an unusual feature that does occur, right? Does occur. Right? And vasculitis mama, the treatment is doxycycline. There is no doubt about that. Clearly, we treat with doxycycline. Right? Doxycycline. There is a question. Leptospirosis PCR සාම වැඩිය පාවිච්චි කරන්නේ නැහැ. ඒක නිකන් හරියම නිකන් රිසර්ච් ලෙවල් එකේම විතරක්ම වගේ තියෙන එක. Okay.
Maybe it's better. Yeah.
So yes, Sajid, there is a place for prophylaxis with doxycycline. In typhus, yes, we use that quite widely in Sri Lanka. Interestingly, this was also something that came out of the Vietnam War when people, American soldiers went to Vietnam and got typhus. They used to take doxycycline prophylaxis. Right. Right. You would have even that also. Right. Okay. Now something about malaria. Right. Now malaria ඔගොල්ලෝ අර මේ කතන්දරේ දන්නවනේ නේද? මේක පොඩ්ඩක් ඉතින් බලා ගන්න මේ. මේවා ඉතින් වෙලා නැත්තම් මේවා බලන්න යන්න එපා. Right? Lepto, no, does not cause splenomegaly. Commonly, it can cause it, but not commonly. Yeah, so MAT is positive because MAT is a sort of an antibody test. It's not directly that, but it's sort of a thing. It takes about 5 to 7 days for it to become positive. Right? Sometimes you diagnose it clinically with MAT test. Report එකෙන්නත් තව සතියක් විතර යනවා. ඒක එනකම් බලන් ඉන්න leptospirosis treat කරන්න. හරි? Yes, but it takes time for it to be positive. හරි. දැන් මැලේරියා ගැන වෙලා නැත්තම් බලන්න යන්න එපා. මේකේ SCQ වලට වගේ අහන්න අහන්නේ නැහැ. සාතිතාවදිනවල microorganism එක demonstrate කරන එක නෙවෙයි, it is the MAT, right? Microorganism is only positive in a very small amount of people very early on in the disease in the urine. හරි? ඒක ඇත්තටම නැහැ. Right, so this thing you have to just have a rough idea about the differences between falciparum and vivax. වෙලා නැත්තම් මේක බලන්න යන්න එපා. ඉතින් මේක හැමදාම අහන එකක් නන් නෙවෙයි. හරිද? Right, remember that falciparum is much more nastier than vivax. The only difference with vivax is vivax can cause recurrences කියන එක තමයි මතක තියාගන්න. හරි? That is the only problem. So vivax අර නිකන් nagging infection එකක් ඕක. Right? Plasmodium falciparum හැදුනා එක්ක මැරුණා එච්චරයි. මැරුණා හරි ජීවත් වුණා දෙකෙන් එකක්. It's a nasty infection, lot of parasites. But vivax is a fellow that can recur. Right? That is a problem. Because it's just hypnozoites, right? Hypnozoites that persist in the liver. Right. Malaria is endemic to Sri Lanka කියන එක පල්බුරුවක්, එක වැරදි. We talked about recurrences. So falciparum, there are no hypnozoites in the liver, so there are no recurrences. Now, Plasmodium falciparum malaria is a very nasty infection, right? Nasty infection. It can cause cerebral malaria, it can cause hypoglycemia, acidosis, multi-organ failure, DIC, very nasty infection, right? Very, very nasty infection. So cerebral malaria in the puluang, DIC in the puluang, hypoglycemia, lots of nasty complications, right? So 3 is true. Now, how do you diagnose malaria? Malaria is traditionally diagnosed by the thick and thin films. Thick film is used for diagnosis. thin film is used for species identification. That is sort of a standard thing, right? But now there are lots of rapid antigen tests which are used also, right? Rapid antigen tests ගොඩාක් දැන් තියෙනවා අපි පාවිච්චි කරන. Right. Now, malaria treatment is now has significantly gone away from chloroquine, primaquine wage, and now we use a lot of this artemisinin derivatives. Artemisinin derivatives for management of mainly for falciparum, severe infection. We use a lot of this IV artesunate artemether artemisinin related substances. Pharmacology right? Because there are lots of chloroquine resistance. For malaria prophylaxis, malaria prophylaxis. Now the drug of choice which is coming up quite significantly is tafenoquine. Right? Tafenoquine, prophylaxis. So mainly for treatment, we use a lot of artemisinin derivatives for both only for falciparum, but also for some vivax. And for prophylaxis, tafenoquine, right? And primaquine chuttak ganno tafenoquine tamai. The main problem with tafenoquine is it precipitates G6 hemolysis in G6PD deficiency. Hemolysis in patients with G6PD deficiency. Right. Okay. Right. Right. Now, HIV is a very important infection, but take a medicine ගොඩක් අහන්නේ ඔය මේ ගයිනකොලොජි පේපර් එකේ ඒ වගේ තමයි ගොඩක් අහන්නේ ඔය මේ STD ගැන. හරි? ඔබ්ස් ගයිනි වල තමයි ගොඩක් අහන්නේ. sorry. ඒ නිසා මම ගොඩාක් මෙතන මේක ගැන ලොකුවට කතා කරන්න බලාපොරොත්තු වෙන්නේ නැහැ. So the two things I am going to say here is that one is this list එක පොඩ්ඩක් බලා ගන්න. AIDS defining illnesses. මේ ඔක්කොම කටපාඩම් කරගන්න බෑ නිකන් උඩින් ඉඳන් පල්ලෙහාට එකපාරක් කියවන්න. හරි? Because HIV, remember, infection, the dangerous thing is when it proceeds into AIDS. Right? AIDS is when your CD4 count drops to very low levels. You get this AIDS defining illnesses කියන ඒවා. මේ ලයිස්තුව පොඩ්ඩක් උඩ ඉඳන් පල්ලෙහාට එකපාරක් බලා ගන්න ඇති. හරි මෙඩිසින් වලට. Right. And then a word about how you diagnose and treat HIV. Right. Now in Sri Lanka we use this fourth generation HIV rapid test to diagnose it. Right. The fourth generation test has the advantage of it is, so this is a screening test. Right, screening test. The advantage of it is that it has an antigen and an antibody dekama thiyena test එක. Right, antigen test එකයි antibody test එකයි dekama එකේ තියෙනවා. ඒකයි fourth generation test එකේ වැදගත්කම. And the antigen we test is this P24 antigen කියන එක තමයි. So in order to diagnose HIV, your screening test is the HIV rapid test. HIV rapid test, and that is it has the antigen and an antibody test combined. The antigen test is the P24 and the antibodies are the HIV-1/2 antibodies. The advantage of using the fourth generation test is because it tests an antigen, it is positive in early infection also. Right? Virus එක ඇඟට ආපු ගමම positive වෙනවා. Antigen එකනේ බලන්නේ එතන. Right? Antigen antibody දෙකම බලන. Right? So that is why it is used now, widely used. For confirmation of HIV, we use the Western blot, right? Western blot එක පාවිච්චි කරනවා. This is a very difficult thing to do. මමත් ළඟදී Western blot එක කරා HIV වලට. මේ වාතයක් ඔක දවස් 3ක් විතර යන experiment එකක්. So essentially you use these various viral proteins to confirm, right? Western blot. You can't use a screen test because it's a lot of lab work involved. And the last thing I want to tell you is that nowadays we start treatment on the diagnosis. HIV diagnosed antiretroviral, highly activated antiretroviral therapy දෙනවා. හරි? ඒක diagnose කරපු ගමන් දෙනවා. Several years ago we used to wait for the CD4 count to drop below 500, 200 ඔහොම ගගේ ඒ කතන්දර කිසිම දෙයක් නැහැ. Diagnose කරපු ගමන් දුන්නා. And now remember that with early commencement of antiretroviral therapy, patients with HIV can lead almost normal lives. Right? ඇත්තටම normal lifespan එකක් වුණත් ගත කරන්න පුළුවන් without problems. So it is one of the diseases that are very well, they are not හොඳ කරන්න බෑ. There are some cases of HIV being cured, but most people, it controls the disease so well that they can lead a normal life without any complications. Right? So, but you have to start the treatment on diagnosis and early as possible. ඔය ටික දැනගත්තා නම් ඇති. ඇත්තටම ඔය HIV drugs වල නම් මටවත් මතක හිටින්නේ නැහැ. ඒ නිසා ඔය ඔයගොල්ලෝගෙන් අහන්නේ නැහැ කවුරුත්. හරිද? මේ there are hundreds and hundreds of antivirals which have various combinations. That's a very specialist area. Even within emergency medicine, there is it's a very specialist area. ඒක විතරක් කරන මිනිස්සු තමයි ඉන්නේ. හරි? So don't worry about that. ඒවයි නම් මටවත් මතක තියාගන්න බෑ. හරි? And I would, even as a consultant, I would never start antiretroviral treatment on my own. So medical student එකෙන් අහන්න එක අසාධාරණයි නේ වගේනේ. Right? So ඔය papers හදනකොට කවදාකවත් antiretroviral ගැන ඕගොල්ලෝගෙන් අහන්නේ නැහැ. හරි. පූර්ණ needle prick incident එකක investigation ගැන අහලා තියෙනවා. ඒක බබෝ දැන් අලුත් protocol එක මම දන්නෙත් නෑ ලංකාවේ මොකද්ද කරන්න කියලා. Because it changes from country to country. So can you please ask ඔය guideline එක ඇති online මං හිතන්නේ. මොකද ඔක වෙනස් වෙනවා. වෙනස් වුණා කියලා මම දන්නවා. මට ඒක මේ මං ගොඩක් කාරින් practice කරලා නැති නිසා ඔහේ දන්නේ නැහැ දැන් current recommendation එක මොකද්ද කියලා. මම හොයලා දාන්නම්කෝ ඔයගොල්ලෝ group එකේ කාගෙන් හරි අහලා. It changes and it changes from country to country also, depending on the facilities. Hari. Okay, now going on to toxicology and toxinology. Hari. එතකොට මේ වගේ නිකන් ඒවා MCQ අහන්න පුළුවන් මේ antidote එකයි drug poison එකයි එක්ක වගේ දාලා නේද? ඔය වගේ අහන්න පුළුවන්. ඒ නිසා මේ ගැන පොඩි අදහසක් තියාගන්න ඕනේ. හරි. මේකේ ඔක්කොම හරි benzodiazepine වලට දෙන naloxone නෙවෙයි flumazenil. Right? Naloxone දෙන්නේ opioid overdose වලට. So this sort of MCQ we can easily set නේ. කරදරයක් නැතුව වගේක් දෙන්න පුළුවන්. Right. Now the next is on paracetamol poisoning. So here I have given you the 3 definitions of a toxic dose of paracetamol. Or a toxic dose of paracetamol. මේවා ඔයගොල්ලෝගෙන් අහන්නේ නැහැ, but නිකන් බලා ගන්න. So remember, you can have a single dose or a staggered dose of paracetamol overdose. Now, the risk of hepatic toxicity is much higher in people who are malnourished, people who have low BMI, probably in females also. There are some studies that show that the toxicity is higher. ඒක ලියන්න එපා. ඒකට පොඩි controversy එකක් තියෙනවා. ඒක එපා. So malnourished, low BMI, people with pre-existing liver disease obviously are at a higher risk of mortality and morbidity. Now the problem with paracetamol is these people who have taken a significant overdose are perfectly fine within the first 24 hours. So that ඇවිදලා කතා කර ඉන්න. ප්‍රශ්නයක් නැහැ. But the important, never discharge them within the first 24 hours. The problem is liver dysfunction can take about 48, mostly 72 hours to start. So that is danger. ගොඩක් වෙලාට ඉන්න ලෙඩා හොඳට කතා කර ඉන්නවා දවස් දෙකකින් විතර flat third day dead. Right? So that is the problem. So liver dysfunction in paracetamol overdose can take can be late and is often late, about 48 to 72 hours from the ingestion. Now, in any poisoning, you know that gastric lavage cannot be done in everybody, right? Gastric lavage best within ඇත්තටම පැය භාගයක් පැයක් විතර තමයි හොඳම lavage. හරි. It's not indicated in all patients. If they come early within about 1 hour of ingestion or half an hour of ingestion, you can use it. Activated charcoal, again for a lot of poisons, can be used up to 2 to 4 hours from onset of ingestion. Right. And the two antidotes that we use, one is methionine, but remember methionine has to be used early, right? I think within 8 hours or so of ingestion, right? Methionine. N-acetylcysteine replenishes glutathione, can be used for longer, and it is the one that we use a lot. Methionine in early overdose, yes, within about 8 hours of ingestion, it is effective, but not beyond that. Right. Any questions? මේවා නිකන් අර නම් බලාගෙන යන්න මේවා මේ මහලුකට අහනේවා නෙවෙයි සමහර වෙලාවට. නිකන් toxicology එක MCQ එකක් පොත දෙකක් තියෙයි වැඩි වුණොත්. Right. The last one is on snake bite. So again, you have to know the venomous eggs and the various sort of envenoming manifestations of the fellows. Right? Hump nose viper does not cause neurotoxicity. The problems with hump nose viper are it causes local tissue necrosis and also renal impairment and coagulopathy. Neurotoxicity in there, actually the most potent neurotoxicity is with fellows like crate and Russell's viper and cobra neurotoxicity. Now, the antivenom that we use currently cannot be used for hump nose viper. Peradeniya were developing a antivenom, but I don't know what the hell happened to that. At the moment, we don't have any effective antivenom for hump nose viper. Right? We talked about this antivenom being used for local tissue necrosis following cobra bite, right? So that is a sort of ascending local tissue necrosis. And during the acute medicine discussions, I also told you one of the complications of antivenom administration is anaphylaxis and allergic reactions. And there is evidence now to say that pre-medicating them with subcutaneous adrenaline, high-risk patients, when you pre-medicate with adrenaline subcutaneously, the incidence of anaphylaxis is less. Right? There's a study coming from a group in Sri Lanka which shows that. Good. And antivenom should not be repeated for persistence of neurological features. You can repeat it for persistent coagulopathy, but not for persistent neurological manifestations. The problem there is neurological manifestations take time to improve. So antivenom repeating is not indicated in that situation, but it can be repeated if there is persisting coagulopathy. Okay. Any questions before we go on to the paper?